Huples Cat. I finally watched this video. A lot of people said, watch this video, and I can see why. If you don't work in an ICU, if you don't know what's really been going on over April and May, you could actually watch a video like this and you might believe it's true. But in fact, it's a very clever fake, a really clever fake. Let's have a little look at this nurse first, shall we?
Perhaps most urgently of all, she speaks of the therapies and protocols employed in her home state that did work. Erin was brought from Florida by a service funded by the Federal Emergency Management Agency.
Well, she's an RN, I knew that when I watched it. But the question is she an ICU RN? Turns out she's registered in Florida since 2017. I'm guessing she was registered in Michigan in 2012. I don't know if it's the same person, but almost certainly is. Usually there's a sidebar identification if the same name appears twice in active registration. But there is different states, so maybe not. But at best, this girl has been nursing for 8 years, and she claims a lot of stuff, and it's apparent to me that she doesn't know very much about ICU. Now, I feel qualified for saying that. I started nursing in 1984 in the United Kingdom. I've worked ICU for years, both in a major teaching hospital doing ICU level 3 trauma, and also in another major teaching hospital doing ICU level 3 transplant. I currently am an administrator, and I work in a lot of different ICUs, and I talk to a lot of different ICU nurses, and I see a lot of some of the issues she talks about in this video. What I don't see is that she's an ICU nurse, and I'll explain why. I have shown bits of this to my partner Kitty. Kitty's been nursing in ICU and currently still does in a level 3 trauma centre, and she was gobsmacked. She could not believe how the girl was presenting it and what she was saying, and she was actually quite angry. As she should. There's also a change petition to get this girl struck off the register of nurses, and I think it's reasonable given how cavalier she is about patients' rights, which I'll explain as we go into this.
So was he, what's the phrase you used? COVID
rule out.
COVID rule out?
So that's how they admit everyone to the floor that doesn't have a positive COVID immediately.
Okay, so he's put in the step down unit, which is a euphemism for step up unit.
Yeah.
And what happens to him there? What's going on there?
What she's on about here is PUI, persons under investigation, in most parts of the world. The fact is that you can't actually test for COVID-19 disease being positive on admission for a lot of different patients. And this also reflects the video. People who've had strokes and can't talk are aphasic, people who've had major traumas and can't breathe, a whole bunch of different people. We can't rule out whether they have COVID-19, so we treat them as a person under investigation. We treat them like they might be. We're not treating COVID-19, we're treating why they came to the hospital. I think that's kind of an important distinction. Also very cavalier calling the step down unit a step up unit. They're really not. Step down units have way more beds than level 3 ICUs, and if that was what was happening, it wouldn't work. It's actually the other way around. Patients go there and they're held there, and we hope they get better, or they hold them there until they get worse and they have to put them in level 3. Level 3 often will put patients back down into level 2 depending on bed state. So it's not really genuine to call it a step up unit. It isn't. She also likes to form limited companies. Interesting, the companies she's formed, you can read this yourself. But she is a very well known blogger, an anti-vaxxer, one of those strong people online that actually generates income from selling her story as an RN, proving that all vaccines are evil. And again, you can argue that whichever way you want, but frankly, I find it very hard to believe that she went to New York out of compassion. I think she went there with an agenda. I think she had an agenda and a script, and she fitted what she found to fit the script. It really sounds like that when you listen to this video. It very heavily, prominently features one particular case, maybe 2 cases, but there's a whole bunch of stuff wrong. Let's get into that.
Oxygen, I wasn't in this unit, my friend was.
So just normal oxygen, nasal?
No, they'll do like a high pressure.
So what does that mean exactly? What does it look like?
It's pretty much like a forced, it almost looks like a big thick nasal cannula and you put it in your nose and it forces the pressure in, it can almost be like, it's still causing your lungs to expand, right? But what they really need to be doing is like the non-rebreather mask, but they just skip it usually. They go right to the high pressure, so their lungs are already,
So what she's on about is a system called OptiFlow that actually gives 100% oxygen, usually, at fair pressure through the nasal cannula here. And what that does, it makes it actually easier to breathe in. What it doesn't do is inflate the lungs under pressure. She again is showing absence of basic knowledge that step-down nurses who work really hard and ICU, full-level ICU nurses would know. It's called OptiFlow. Everybody calls it OptiFlow. And it doesn't inflate the lungs. It allows pressure oxygen, like squirting of oxygen here, so when you go, try and breathe in because you're weak, it's easier for the oxygen to get into the lungs. It's not a pressurized system into the lung at the alveoli level.
And were you having better outcomes there?
Yeah, we didn't have this because we treated them properly,
What would you say the kind of the case fatality rate was?
None. 0. Yeah, by me, 0.
So that's a load of misinformation there. I'll just quickly explain it. She worked in Florida. Florida, you can look at their case fatality rate, it's pretty clear. There's also subcontext here that private hospitals treat people better than public hospitals because public hospitals are trying to get money. They get $29,000, apparently some of them, for treating a COVID patient. It costs about $10,000 US minimum per day to have somebody ventilated. It just doesn't make financial sense what she's saying. Other than the fact it doesn't make sense. She also claims certain things throughout the video that actually are treatments for this that will drop the case fatality rate to 0. One she has a discussion with the doctor on is vitamin C. Now you do know that vitamin C is associated with immunity. There's been numerous trials in intensive care units all across the world that show categorically that high dose vitamin C in sick patients does nothing at all. Nothing. She also talks about hydroxychloroquine, which again has been shown to do nothing. The trials that were done during SARS in 2003 categorically showed high doses of the anti-malaria drug did work on the SARS virus and worked very well on the SARS virus in primates. In all human studies that are any reliable at all, hydroxy kills people. Okay? And it's took months of nonsense from certain people with certain agendas to finally get the world to the place where almost everybody accepts the fact it doesn't work. In fact, it could be very dangerous. And she talks about non-rebreather masks. A non-rebreather mask is a 100% mask, and you just breathe, and it doesn't allow the air to escape, so the oxygen concentration remains high. It is the go-to treatment for anybody short of breath, unless they have COPD. Then it kills them. She's claiming in her hospital in Florida, though she's pretending it's Midwest, where she worked at least before 2017, she's claiming that everybody's thrown on 100% oxygen non-rebreather mask, given vitamin C and hydroxy, and nobody dies.
Pressurization of the lungs that is also causing harm?
Yeah, they're having the PEEP, that's the pressure in his lungs, which is causing this barotrauma of people. It's blowing people's lungs out. So when that happens, what do you got to do? Turn it up more. You just keep.
Because the membrane expands, so that you need, in order to fill them and deflate them, you need more pressure.
Yeah, you're gonna have to.
PEEP is positive end expiratory pressure. When you put an airway tube in, you remove this amount of dead space. So you need a little bit of extra pressure after the exhalation to make up for this dead space. So typically 5 is used, typically, and it can go up to 12.5 in certain patients. What she's claiming here is absolute nonsense. When you have barotrauma, i.e. pressure trauma to the lungs from ventilation, which is a side effect of ventilation, what you don't get is the lungs going like this and getting very tight. What you get is rupture of the alveoli and movement of air where it shouldn't be. The treatment for this isn't increasing PEEP, it's to emergently insert a chest tube, or the patient dies very, very, very quickly. She doesn't seem to know that. She doesn't seem to know what PEEP actually does. There's a whole bunch of different treatment modalities, IPPV, a whole bunch of them. I'm not going to get into it, pressure support, a whole bunch of modalities. She doesn't seem conscious of those modalities. She doesn't seem to know what modern ventilatory treatment is. But I will say, when COVID-19 started, we treated it like SARS in 2003. And during SARS in 2003, a lot of ICU nurses, doctors and patients were infected by using non-rebreather masks going to higher levels. Optiflow, BiPAP, which he never mentions particularly, that aerosoled it and infected everybody around them. So initially, all around the world, as soon as the oxygen levels dropped and they became and they were struggling and they couldn't actually talk, we would intubate electively. Boom. We weren't waiting for terrible, terrible things to happen. And we did that to avoid them infecting us. After about 2 to 3 weeks in Toronto, it was apparent that we were having an 80% death rate from most of these patients. So we actually changed it. We only electively intubate now when they lose consciousness. Consciousness is a critical sign of oxygen flow, not saturation. There's a whole bunch of reasons why peripheral saturation isn't any good. And while we're on that topic, the one thing that's commonly used in ICUs throughout the world, is arterial blood gases. She never mentions an arterial blood gas. I doubt she knows what one is. She never mentions arterial lines. I doubt she even knows what one is. She's focusing on very basic nursing interventions that, frankly, you wouldn't see only done in an ICU. Specifically when she claims killing people for money, they would be using high-end modalities, but actually everybody would use gases. What's their CO2 level? What's their pH of their blood? What's their oxygenation? What's their bicarb? That is critical to decision making, except for when they go unconscious. When they're going unconscious from this, we do intubate, and we have an airway protected team to do it. But you don't get 100% mortality, even with the treatments that she's claiming she's seen. What she's seeing is a little bit of medical incompetence and fear and freak out in the beginning of this. And yes, we did electively intubate people, and yes, they died. Would they have then progressed to be intubated and died anyway? I don't know. We don't know. What we do know is that we're now heavily using the intermediate pressures, not non-rebreather bags. They do nothing. They do literally nothing to help with the airway alveoli issue. They increase the oxygen level in your SAT probe, but that's not helping the person. What helps is extra pressure to allow them to breathe easier, because the pressure's held at the end of expiration, so when you breathe in, it's a lot easier. And also we let them breathe out easier as well. And typically, I'm telling you right now, these patients don't have massive chest secretions, which she claims. They don't. They're dry, mostly. The other thing we did wrong is we gave everybody large amounts of Lasix, which is furosemide, which is a diuretic, and we figured that their alveoli was wet because we were seeing white spits, not white occlusion, on chest x-rays. It turned out that no, what we were seeing is the virus in the alveoli. Maybe clotting, we don't know. We're still looking at that. This has definitely got a clotting effect. When we dried them out so badly, they lost kidney function, which wasn't good. All of those things we figured out in the first 2 or 3 weeks. She's doing this in the middle of May. She's claiming this is still going on in that hospital in the middle of May. Now, there are doctors online from that hospital who vehemently disagree with what she's said. There's also nurses online who worked with her who vehemently disagree with what she said. She is selectively talking to certain people at certain times in certain ways and editing it to give them the impression that public hospitals are killing black people for money. And none of them should have died. None of them. Again, this is the agenda of the right wing. I'm sorry, but it is. COVID is nothing. You don't have to die from it. Take hydroxy and vitamin C. Go back to work. Business normal. This is not this case. It's killing hundreds of thousands of people. Before this is over, it will kill millions of people worldwide. The question is, do you want it to kill millions of people worldwide or not?
And what oxygen level are they put on?
It depends. I mean, as they start to deteriorate more and more, then the oxygen obviously is going up.
Other than preterm neonates, for very specific physiological reasons, when we intubate anybody, they're on 100%. The bag, the ampu bag or lead bag, and the ET tube are connected to a wall oxygen source, which is 100% oxygen. There is no what oxygen we're putting them on when we intubate them. Yet again, yet another clue that this nurse has no idea how to function safely or appropriately in an ICU setting. And I could go on. It's riddled for me, this video, with major red flags that she's lying. And it's a horrible thing to say. She's lying. She has an agenda, and she's lying and fitting facts to make people believe certain things. And I'm not going to get into the rest of it. There's a whole whack of things in here, but I am going to show some stuff. I just want to point out to you people that registered nurses are a trusted profession, probably the most trusted profession. One of the reasons is we don't have conversations in front of patients about stuff that might upset the patient, specifically when the patient's very ill and can't talk back. You don't do that. She does that. She doesn't care. She does not care about any of those patients that she's helping with. Now, I do believe, from what I understand, what her role there was, they hired a bunch of nurses. Will you come? Will you come? They all came, and they were given a couple of days orientation or 4 hours orientation, and they were buddied with experienced ICU nurses to do things like helping with turns, right? They weren't actually replacing or working in the ICU as an ICU RN. They were physical bodies to help the ICU nurses, who were very stressed and short-staffed, deal with this emergency. And my hospital has done the same thing. None of the nurses who are working there in those hub setups we've got would ever claim that they're an experienced ICU nurse with years of experience, like she does. Boy, she did fool people.
The guy over in... Yeah.
That were two negatives.
And they're positive. Like the guy over in 29, I had him upstairs because I was on CCU before it.
Yeah.
And he came in with a stroke.
I know, that's what 26-1 was, a stroke.
And no COVID. And now he's got COVID and he's on a vent.
Because we gave it to him here.
I don't know how this ended up being COVID central.
I know, but she literally came in with a broom, and then she left like 5 minutes later. My patient had died of COVID, and she didn't mop the floor.
Patients are referred to by their name, not by their bed number. The person in that room lying there while they have this heated conversation has reasons to report all of those nurses to their licensing authority and have them suspended and disciplined. Absolutely outrageous. The other outrageous thing with this is nobody is positive for COVID unless they've had a positive swab and then deteriorate and then get hospitalized. In New York and everywhere else, people at home not feeling very well and go to the hospital. They haven't been swabbed. We don't know if they have COVID-19. They look like it, so we treat them like they have COVID-19, which is supportive therapy, which is high dose oxygen if they can take it, pressure support, BiPAP, Optiflow, ventilation, to reduce their work of breathing, to help them breathe without them dying from the brain death before their own bodies can recover to fix the infection. We don't actually fix the infection, we can't. There are treatments that are being looked at, but I can tell you vitamin C does not work, hydroxy does not work, and not ventilating somebody who can't breathe is criminal murder, right? The reverse is also true. Now, the other thing that's a big red flag to me, I'm a hospital administrator, I work nights, I'm the only administrator in the entire hospital, and it's a major teaching hospital in Toronto, a trauma centre. Guess which one? The nurses are faced with cleaners who have not done a good job. Now, I'll tell you right now, it's highly, highly unlikely. There's a ton of supervisors for cleaning. When you do COVID cleaning, it's a two-stage cleaning. What happened here was odd. Most of the hospitals have electronic tagging systems for bed cleaning, but why would the nurse not tell their charge nurse? Why would they not call their nursing supervisor? Why are they just standing there bitching? If you listen carefully, what you're hearing is nurses on a floor that's now taking COVID patients because of overflow who are unhappy about it. And they're claiming that everybody's negative and then they become positive when they're here. That's actually not actually true. The room they're also in is a semi-private room. There's 2 patients in it. Again, I'm kind of wondering what's going on there, because that probably happened for certain types of patients. It did not happen for non-COVID at all and probable COVID. That never happened. And I'm kind of curious as to how she faked this to get this impression over that they're literally wantonly just putting anybody anywhere they like and they don't care. But don't be fooled by stuff like this. It's very easy if you're not in the system. Like when people look at police videos who aren't police, it's very easy to make specific judgments, especially with agendered and tailored political videos that aren't true, just aren't true and do not represent reality at all. And that's what happened with this. I've had numerous, like I say, I've had numerous subs tell me to watch this video, watch this video. I've watched it. It was awful. It screams of fake to me. It really does. It's appalling. It's so bad that if she isn't suspended and possibly removed from the register of nurses, that's disgusting. She is so badly lying. She has so lack of information about ICU. She's pretending to be something she is not. That's a clear ethical and legal violation of what a registered nurse is supposed to be. And I know people on her comment section said, I'm in my hospital and I agree with what she's saying. It's an interesting thing how people are looking at the world through their own lens. Try not to be left-wing or right-wing with a pandemic or any SHTF. It doesn't care what your ideology is. It's got its agenda. Its agenda is to infect as many people as possible, not to kill most of them, and to spread successfully. That's COVID-19 disease's objective. She claims many things in this video which are appalling. And frankly, I didn't find any evidence at all watching this after 36 years of nursing, over 2 decades of intensive care, real intensive care. I actually worked in SARS. I looked after 40 SARS patients in the ICU. Yes, this is a scary time. Yes, there's a lot of unknowns. Yes, we did a couple of things wrong early on. We ventilated everybody very early on. We don't do that. We haven't done that for months. And we dried everybody out. We used what we used in SARS that worked. It didn't work in this case. And now it turns out that we're going to use steroids. Again, only for people who are extremely, extremely sick. If you start taking steroids and you're not very, very ill, you're likely to have long-term complications of that steroid, and you would never have died from the disease because it doesn't protect you from the disease. It helps you recover from the disease, and it's also reducing your immunity. So another problem we're probably going to face is people out there who don't know anything starting to take steroids prophylactically. And that's going to be a whole different ball game. Anyway, please feel free to argue me below. I have got some stuff in the description where you can actually look at some of the source material I used for making this video. But overall, please stop looking at the world through a biased lens and seeing reality that you want to see. It's not helpful to you. It's not helpful to me. Toodles.
Alright, come here, baby. Yeah, come here. Come here. Sit.
Always compliant.